facing a health diagnosis, it could bring up a lot, can it? Questions, maybe some anxiety, especially when it involves your feet and complications that can come with diabetes.
Absolutely.
So today, we're doing a deep dive into peripheral artery disease, or PAD. We're focusing specifically on how it affects people with diabetes who also have foot ulcers.
Mm-hmm.
And this is really for you listening. We want to cut through some of that dense medical talk and give you a clear, usable understanding.
Right, so you can feel more confident talking with your own healthcare team. That's the goal.
Exactly. So let's start with the basics. PAD. What is it, and why is it such a big deal for someone with diabetes and a foot ulcer?
Well, PAD, peripheral artery disease, it's essentially a plumbing problem in your legs. The arteries get narrowed or blocked, usually by plaque buildup, kind of like rust in a pipe.
Okay, restricting flow.
Precisely. And it's surprisingly common. If you have diabetes and develop a foot ulcer, there's literally like a 50-50 chance that PAD is involved.
Wow, 50-50, that's high.
It is, and it seriously ups the risk for complications. We're talking about things like much slower wound healing, infection, and unfortunately even amputation. Plus, it's a red flag for heart issues, too.
So every foot ulcer in someone with diabetes should ring an alarm bell for PAD, basically.
That's the crucial insight, yes. Even if you're not feeling the classic leg pain symptoms.
But you mentioned classic symptoms. Why might someone not feel them? Why is PAD sometimes tricky to spot, especially with diabetes?
Ah, that's a key point. Diabetes itself can actually mask the symptoms. Nerve damage, or neuropathy, which is common in diabetes, can dull the pain signals you'd normally feel.
So you might have poor circulation, but not the usual leg cramps or pain.
Exactly. Plus, there's something called medial artery calcification, basically. The artery walls get stiff and hardened, also common with diabetes. And this can actually make some standard diagnostic tests, like the ABI we'll talk about, less reliable.
Which makes getting the right diagnosis early even more critical. Okay, so how do doctors figure it out? What's in this diagnostic toolkit?
It really starts with regular foot checks. Annually is key, even if you don't have an ulcer. Your doctor should be asking about your history, doing a physical exam, and importantly, feeling for the pulses in your feet.
Just checking the strength of the blood flow by touch.
Yes, that's the first step. If PAD is suspected, or if you have an ulcer, then they move to some simple non-invasive tests, often done right there, bedside.
Okay, let's break those down for everyone.
Sure. First up is often the ankle brachial index, the ABI. It's straightforward, compares the blood pressure reading at your ankle with the one in your arm, gives a ratio.
Like checking the pressure difference.
Sort of, yeah. Then there's the toe brachial index, or TBI. Similar idea, but measures pressure at the big toe. This can sometimes be more accurate if those ankle arteries are hardened, like we mentioned.
Okay, ABI, TBI. What else?
And pedal Doppler waveforms. Think of this like a mini ultrasound for your foot's blood vessels.
So they listen to the blood flow.
Exactly. They use a small handheld device, put some gel on your foot, and literally listen to the sound the blood makes as it flows through the arteries. A weak or absent whoosh sound can indicate a blockage.
And you probably use these together, because one might be off due to the diabetes.
That's the smart approach, yes. Using them in combination gives a much clearer picture. And the good thing is, these tests are generally pretty accessible, low cost, and a trained nurse or doctor can do them easily.
Okay, so we've diagnosed PA. Now what? How do doctors figure out the outlook? Like, how likely is this ulcer to actually heal?
That's the next critical question. Prognosis. While the ABI gives clues, we often look more closely at specific pressure measurements for healing potential.
Such as?
Well, toe pressure is a big one. If that pressure is 30 millimeters of mercury or higher, that's generally a good sign for healing.
30 or higher, okay.
And even better, potentially, is something called transcutaneous oxygen pressure, or TCPO2. It measures oxygen levels right through the skin near the wound. A value of 25 millimeters of mercury, or more significantly, boosts the odds of that ulcer healing.
So higher pressure, more oxygen getting there, better chance of healing. Makes sense.
Mm-hmm.
This brings up something really important, I think. If you have a foot ulcer and it's just not healing, what should you be thinking? Or asking your doctor.
That is such a critical point. If an ulcer isn't healing, it's a signal. Don't just assume it's, just because of the diabetes, or blame it vaguely on microangiopathy.
Explain that term a bit. Microangiopathy.
Right. It refers to damage to the tiniest blood vessels, the capillaries, and yes, that happens with diabetes, but it should never be an excuse to stop looking for treatable causes in the larger arteries, which is what PAD is.
So don't let that term shut down the investigation.
Absolutely not. You need to explain everything. Is there an underlying infection? Is there too much pressure on the area, what we call offloading? Is swelling an issue? Nutrition. And of course, is overall blood sugar under control? It's detective work.
And doctors have tools for this, right? I think you mentioned WIFI.
Yes, the WIFI classification. It stands for wound ischemia, which means lack of blood flow, and foot infection. It's a way for the clinical team to kind of stage the severity, looking at all those factors together to guide the best treatment plan.
Okay, so you've investigated, you know PAD is a major factor. What's the most powerful treatment step to get that ulcer healing?
Restoring blood flow. It's called revascularization. Think of it, again, like clearing that clogged pipe. If you don't get the blood supply back to the tissue, nothing else you do will be nearly as effective.
Makes sense. You need the building materials delivered by the blood.
Precisely. And getting that flow back can dramatically improve. Healing studies show over a 60% chance of ulcer healing after successful revascularization. And it can save limbs. We see about an 80 to 85% limb salvage rate.
That's huge. Limb salvage.
It's life-changing.
And you mentioned urgency earlier. When is it absolutely critical to get that vascular specialist involved? Like right now?
Urgency is key if the blood flow is severely restricted. For example, an ABI rating less than 0.4, that's really low flow. Or if there's obvious infection, like spreading redness, pus, or worse, gangrene.
Gangrene being dead tissue.
Yes, dead tissue due to lack of blood flow. In those situations, delaying consultation with a vascular surgeon or specialist significantly increases the risk of losing the limb. It needs immediate attention.
So revascularization is powerful, but it's not the whole story, is it?
Not at all. It's a vital piece, maybe the cornerstone for healing the ulcer, but the best results, the long-term success, comes from a team approach, a multidisciplinary team, meaning you need experts managing the infection, skilled wound care specialists, people focused on offloading, getting pressure off that wound using special shoes or casts, and crucially, managing your overall health.
So connecting the foot problem back to the whole body.
Absolutely inseparable. Managing your blood sugar is vital. The target for HbA1c, that long-term measure of blood sugar, is generally under 8%, but that's always tailored to you.
Right, individualized.
And blood pressure control usually aiming for below 140 over 90. Cholesterol management too, especially the LDL or bad cholesterol, often aiming for less than 1.8 millimoles per liter.
And medications play a role here, too.
Definitely. Things like antiplatelet therapy, maybe clopidogrel, or sometimes aspirin combined with a low dose of rivaroxaban help prevent clots. And some of the newer diabetes medications like SGLT2 inhibitors or GLP-1 receptor agonists have shown benefits for both heart health and reducing limb complications in people with type 2 diabetes and PAD.
Wow, so those diabetes meds do double duty sometimes.
They can, yes. But again, all these targets and medication choices are very specific to your health situation. It's a conversation to have with your team.
So, wrapping this all up, what's the main takeaway for someone listening, maybe feeling a bit overwhelmed by all this?
I think the main message is empowerment.
Yeah.
Understanding these things, what PAD is, how it's found, how it's treated, the importance of overall health, it puts you in a much stronger position. You become an active participant in your own care.
It's not just things happening to you, but something you're involved in managing.
Exactly. This isn't just about doctors deciding things. It really is, or should be, a partnership.
So use this knowledge.
Yeah.
Start conversations with your doctors, your nurses, your podiatrists.
Yeah.
Ask questions.
Please do. The journey with PAD and diabetic foot issues, yeah, it can be complex, no doubt. But your engagement, your informed questions, they can genuinely make a difference in your outcomes, in preserving your mobility and maintaining your quality of life. That active role is maybe the most powerful tool you have.